excess forward and limited going backwards, or disproportionate ratios. But very rarely a provider will ever literally grab up, and you'll see the little bubble measuring device. That's what you're supposed to be able to use. The consistency between providers is not great. We'll talk about that in a minute. But then when the equipment that you can show that does research, that's where we'll head after this. So document loss of motion, excess motion. This is our standard across the country in documentation. Ligament injury, we'll take and see x-rays, and we can see as far as some injuries on there, but not every provider will take and do stressed x-rays. Pain, that's your assessment tests, and then of course your visual analog scales, being able to, the patient reporting, I'm a 5 out of 10 today, or I'm a 10. Like, you're walking, everybody is different, and every region of the country is different too. So in saying that, so in this area, would you say that your clients are a little tougher than other clients in the country? I mean, out west, they don't want to complain about much, or they're like, I'm good. That ends up being a big struggle, and what happens is, if the provider understands that philosophy, because we all want to go back to just, I'm good, I just need to go about my daily life and get things done. But when we go in and document and follow up with examinations every 30 days, and we do our x-rays and we assess for those ligamentous injuries, when they start to see that, their eyes get bigger, and then it becomes real for them. They're understanding what's going on more in depth because their doctor was more, I would say, looked into it more and was able to describe to them what's going on. I was just talking with Jim about when we go through and we're checking our patients, as far as checking that lumbar spine or that cervical spine, we really try to describe to them, like, what is the texture of the tissue. Like, this is, normal tissue feels silky when you push through it, and it just flows. But when there's damage to it, what happens is it tears the tissue, makes scar formation, spasms in it, trigger points, and you see these areas that are chronic pain complaints for people. And we describe them, we call it table talk, and we train on table talk, and we like to be able to talk to them about what's improving or what's not improving. You may be feeling better today, this knot right here is actually bigger. It's not going away. Or you're feeling horrible today, but this joint's actually moving finally. You know, and you have to be able to describe to them what's going on, how their case is improving. Or else, number one, they don't stick with care in our offices. You know, that's one thing. But then being able to describe the case as a whole. But as far as back to this area, we just have to make it real for them. And they overstate their progress, but we need to be able to be objective and show them the areas where they're still deficient. Imaging, x-rays, MRIs, video fluoroscopy, nerve conduction studies. Has everybody used video fluoroscopy? X-rays, I'm sure. MRIs, obviously, yeah. So a lot of the tests that are out there, and we'll talk about this as far as future areas to be able to teach on, as far as whether it's different areas of the body. But this video fluoroscopy will be very interesting. We'll talk about it in a minute. But when we have a cervical spine, does anybody know the number? If it's over 3.5 millimeters tearing in the ligaments, what percentage of a whole body impairment that is? Does anybody know? It's between 24 and 28% of whole body impairment if you see this on an x-ray. Has anybody ever seen a flexion extension x-ray depicting that? So I'll read the definition from this Physiopedia. So clinical instability of the cervical spine is defined as the inability of the spine under physiological loads to maintain a normal pattern of displacement so that there's no neurological damage or irritation, no development of deformity, and no incapacitating pain. You have to go to a definition, and now we have to put it in a picture, and I'll give you some information on how, and on the anatomy side of this. So I'll use my spine, I'll talk about these two pictures here, and we're going to talk about two pretty important ligaments. We're going to talk about the ALL and the PLL, okay? A is for anterior and P is for posterior, and they're just longitudinal ligaments along the spine that hold them together. If they get torn, what ends up happening to them? So you can see this one right here. These are the bumps on the back of the spine right here. These are the vertebral bodies, the squares here. This is a disc. This is just two segments that got placed up here. And then this canal back here is your spinal cord, like where it lives. okay? If you have a disc herniation, this disc pushes back there into that canal and pushes on the spinal cord and causes lots of nerve problems, muscle weakness, and sensation, referring pain, those types of things. So, let's see this. So place this like this, and we'll talk about neck, a little bit about low back, but there's a study, it was a cadaver study. I'm going to talk about two of them, really important. So cadaver 1 and cadaver 2. Cadaver 1 study, does anybody need paper, by the way? They're $1.50. So when we take and go through the cervical spine, if you want to depict an instability, you have to be able to put it in a different position. And so the instability will look, this is a normal neck. This one's like this, looking up. This is a stress study, okay? And you can see each of these bones right here, and they're all nice and lined up. Like I draw a line and it just cruises right up, right? It's not a very bumpy road driving up that ligament. Same thing on this side. Coming up all the way, there's no big step defects, okay? This is where that millimeter of change is extremely important. This one, flex it forward, you can see that there's a little bit of buckling here, but this is pretty normal. There's no translation of the bone. I would say they need an adjustment, but that's about it. So when we go through in this one, this is a personal injury case that since I got back into practice a year ago, I was able to help this person and get them to where they can go about their normal activities of daily living without severe headaches, without vertigo, without all these other symptoms. So in this case, this is when they came in, you can see it comes up, and then it kind of has this buckle that comes forward. So the doctor goes, what's going on there? So then let's flex that thing forward. Hey Lisa, we need to take some x-rays. Will you follow up and do a flexion extension on that? Because that doesn't look great. Let's do it. So here's the first vertebrae, here's the back of the head, the jaw. So 1, 2, 3, 4, 5, 6, 7. There's 7 bones in the neck. Let's drive up the back of this one. First step, that's about 2 millimeters. Here's one about 3 millimeters. Here's one that's 5 millimeters, and this one's about 4.5, 5 millimeters as well. So we have 2 levels that are significant instability in the cervical spine, or a buckle in it. So what percentage of whole body impairment ends up being when you see this in an x-ray? Does anybody remember? 24 to 28. We asked me high, right? So, and then up at the top of the neck, this is what scared me at first. This is really important because this is the first one. It's like a ring, and it's called your atlas. And it's this guy right here. But there's a bone on the inside of it coming from the second one underneath it. So I'll put my hand like this in that ring. The second bone comes up and pushes right up against here. So, and this is even way more intricate in evaluation than what we're talking about today. So you can have a collision or impact and you can tear the ligaments on this. This is tears, but I can't say it's over medical instability. So, because if it's over 3 millimeters, what ends up happening is it starts pushing on the spinal cord. That bone tears away from the bone in front of it and starts pushing on the spinal cord. So then they're getting these symptoms and they're getting clumsy and walking. Really big, bad stuff. So this case was really interesting. You cannot sit there and adjust this spine like the chiropractors in our area. If you do, you're just going to make this worse, 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 worse. Okay? So this table over here, we utilize traction to be able to force a fulcrum in the middle of this spine and push this buckle right here. This is her after 6 months or 7 months of care. And you can see the buckle's improved about 50%, but it's not all the way yet. So we still have another 6 months to a year before I'll x-ray again. She uses this foam fulcrum that we utilize over here, and that purple display, that chiropractic biophysics, is literally the single most researched technique in chiropractic. There's 210 research articles that are produced, and we're in the middle of going through a publication and having one of our cases published, and I'll talk about that here in a minute. So she is symptom free at this point, okay? And then we'll end up testing to see if we can get that instability as far as fix it down the road. So I'll have a flexion extension view down the road, and I'll be able to follow up with you in 6 months or so and show you as far as how that goes. That was a case that was within the last year. Here, this next one that's 25 years ago. bust their teeth out, bit the dash, car rolling, all that stuff. Significant whiplash mechanism of injury, right? And severe tearing of the soft tissues within the neck, and caused lots of pain. She did everything possible that you could do to try to get rid of this over the last 25 years. Super frustrated. And I didn't fix all of her symptoms, by the way. Not yet. Give me time. So in her neck, she holds her neck very far forward, okay? Extreme anterior head carriage. And so you can see this case, but the ribs come off the vertebra right here. And so then there's a couple muscles that come up right here, and there's a doctor that cut the ribs out of her, right? And to be able to solve the symptoms. Didn't help her one bit. If I would have known her 20 years ago, we would have been able to help her. Right now she's about, it depends on what symptoms we're talking about, but I'll show you that here in a minute. I want to go back to the cadaver studies that I flew past here. So we talked about that tearing of the bones, right? So cadaver 1, cadaver 2. Cadaver 1 is the guys, the researchers, right? And they went in there and have all these cadavers, and they had the X-ray machine. So I shot the cadaver with the X-ray, and then they flexed the neck up, took the X-ray again, and then they dropped, and then they went back in with a scalpel and cut the back of the spine, and went through and specifically cut the ligaments at this level, right here, in between the vertebra, this, and then flex the spine. Zero translation on that X-ray. So this is the no impairment, but that's a pretty big impairment, right? So the next one was they cut the capsules, and then they went inside it and cut the ligament called that PLL, that posterior longitudinal ligament, and that's where the bones stick together. Will you pass those bones around? Adam, will you grab that? Just grab one off of it, like a coffee cup, yeah. Pretend you're at Starbucks. And then, so the way that's set up is you can tip those bones forward and backwards. They're supposed to articulate and tip. It's called the instant axis of rotation, instantaneous axis of rotation. And so, so then they took this ligament that's back here where the nerves are, and they cut it back in here, and that bone on the X-ray is now sliding forward. So you can run that on. And so then they took the X-ray again, shot it forward, and until they cut all those structures, that's the first time they saw that instability. So now we have to go along and along with this. So we've been able to reproduce the imaging, okay, on dead people. And now let's go on dead people again and do this as far as let's go in and take this tissue, and we're going to do microtome studies, put them in a car, literally, and then run into the car and tear that tissue. And so they take a microtome, which cuts layers of that, literally, like, and they go through histology-wise and look at the layers of that tissue. And they're like, oh, that one's inflamed. You can see bony damage, facet, joint damage. So when I say facet, it's the joint on the back here. So they're cutting layer by layer, looking at under a microscope. And they could see damage to the joint right here where my finger's sitting. You could see damage to the ligaments back here, but you can't see it on MRI or X-ray. And so they're able to see the invisible injury then through microscopy, but it didn't show up on the MRI, it didn't show up on X-ray. So you can use this as far as almost go the other side of it when there's an argument. No, you absolutely can look at cervical spines that are damaged histology-wise from a car accident, but they don't show up on X-ray or MRI. So your cases that come in, and I put them through, and I do a flexion extension view maybe, and there's no instability. Don't get all upset. There's still soft tissue that's hurt. Sometimes you can look deeper in the MRI and look at and see some swelling within the bone, some within the facets, those types of things. So that's the cadaver 2 study. So both dead people, one was cutting the tissue and one was cutting the tissue by looking at it through a microscope. But the difference was the X-ray. One was showing X-ray tearing and one was not, or X-ray on, tearing on X-ray. So here is Linda's neck. So and I got permission to be able to use her case because we're taking it through publication. But this collision, I was talking about the nerves that come out right here and go down the arm. This is where the rib is cut out. And so this translation of anytime you have chronic pain, you'll see anterior head carriage, like you'll see asymmetry in